again, I'm Tiffany Knauf. I am the Health Systems and Pharmacy Coordinator at Department of Health and Human Services. I am also the State Chronic Disease Director for NACDD, and I have no financial relationships. Couple learning objectives. We're going to talk about CHWs. So I need you to raise your hand if you have heard the term community health worker. Okay, keep your hand up if you know what a community health worker does. If you do not know what a community health worker does, you're not really confident, because if I call on you, I might want you to defend it. Okay, do you think that you could potentially have a community health worker in your practice? Okay. Who's a pharmacist in the room? Okay, who's a pharmacy tech in the room? You guys are going to be my friend. Who's other? Yay, that's me. All right, so good to have you all here. Thank you. It's just helpful for me to know who I'm speaking to and what questions that you may have as we go through this. So what is a CHW? Truly a frontline public health worker that can be located in a ton of different settings. Everything from our FQHCs to our pharmacies, to our food pantries, to our health systems. They can be placed just about anywhere. They connect people to care and resources. So we think about how hard it is to navigate healthcare, how hard it is to navigate this building. Anybody else get lost in this building? Because I needed a student to get me here because I was in the cafeteria. But thinking how complicated that is, and then thinking about how do we get our patients that have the highest needs between healthcare and community, right? Whether it's this building or it's the food pantry, how do we get them there? They have lived experience. I'll tell you, I cut my teeth in public health as a 23-year-old leading a public health unit in New Mexico. Population in that community was about 50% Hispanic, and they will tell you that the border crossed them, they did not cross the border. Their family was there well before the border even existed. And we called community health workers there promotoras. My primary communication with promotoras was having them help me communicate with individuals who maybe don't speak English well enough to talk about community resources, to talk about healthcare related challenges, to fill out forms. We don't think about that. Believe it or not, the state of Texas has community health workers, but they don't have their community health worker certification application in Spanish. The state of Texas, it specifically says on their website, not available in Spanish. Seems like a problem when the individuals are designed to be part of that community. They truly serve as an advocate, an educator, and a navigator. So some key functions, as we've talked about, health education. So answering questions about maybe new medical information that they have, new family challenges that they have, care coordination, resource navigation, and patient advocacy. When we think about social determinants of health, so often we're afraid to ask the questions. We're afraid to ask about housing security. We're afraid to ask about food security. Why? Because we have to deal with the answer. We had a health system in our state who I love dearly turn on their SDOH screening, because that's what good health systems should do, right? One of the first days that it was turned on, a patient indicated that they were not safe in their home. So domestic violence type situation. They didn't have a protocol on what to do if that came up. How do you reach out to that patient safely and ask them about this situation? So what did they have to do? Leadership said, shut it off. So for 6 years, they stopped screening for social determinants of health. So it's really important to have someone within your setting, especially if you're screening for social determinants of health, to be able to assist as a community member, to assist as someone who isn't in a white coat, no offense to all you pharmacists, but y'all are a little intimidating to a community member that may have food insecurity or may have a domestic violence situation. Those are hard things to admit. But if I come to you in real casual outfit and we're just having a conversation, it's different, right? Evidence of impact, CHW interventions reduce A1C, improve blood pressure control, and increase preventative care. And pharmacists, integration with pharmacists can lead to adherence. My first interaction with Mr. Stagg over there was a bajillion years ago, I think 10. He presented at the Hypertension Summit for me, and I still use his graphic about medication adherence for hypertension. We know if we can't get those patients to take those meds, there is no chance we're going to get them in control. But you know who can? Somebody who is of their community that can help explain it, not from the Dr. Petrie language, but from the Tiffany Knauf public health language, right? And I mean that of no offense. But really, it's a lot. It's scary to take meds that you don't understand. So let's talk about how pharmacy and CHWs can work together. I want to be completely clear. I do not expect any of you to post a position tomorrow to hire a CHW. That is not my intention of being here. My intention of being here is taking these amazing pharmacy techs that are sitting in front of us and giving them an opportunity for career advancement to also be cross-trained as a CHW. Okay? They can be cross-certified. They'll be registered with Medicaid and be billable providers within Medicaid. And they will have a very distinct owned role within your pharmacy. How powerful. Okay? So much of what they're already doing, now they're going to be helping bring more into the pharmacy. And not just talking about dollars, but truly helping your patients, okay, in a very different way. So pharmacy techs are eligible to become certified CHWs in North Dakota. They can provide that patient education, that follow-up, that resource navigation as part of your pharmacy workflow. So as Jamie and I were talking during the communication time here, why couldn't a CHW do some of the aging screenings? They can. They could also go into the home of your patient and get reimbursed for doing some home assessments. Does the patient have a ramp to get into their home now that they've been newly discharged with a walker or a wheelchair? Do they have a grab bar in the shower to make sure it's not a fall risk, right? All those types of things that you're going to learn by going into the home can be done by a CHW. And oh, by the way, they could probably deliver that patient's meds at the same time, right? So CHW services do not have to be billed within the four walls. And actually, if you ask Medicaid, they would prefer it not. They would prefer CHW services be done in the community. Doesn't mean they can't do it in the four walls of the pharmacy, but Medicaid actually wants them to not. So what's the pharmacist's role? For CHW services, there is, for Medicaid reimbursement as well as Medicaid expansion reimbursement, a requirement for a documented referral. That referring individual can be the pharmacist. So pharmacist or pharmacy tech / CHW, you say, hey, Jane's coming in today. Last time I saw her, she looked like she hadn't showered in a week. She's having a really hard time paying for her meds. I think we should do some additional screening. Great. Pharmacy, Brody says, sounds good. I'll put in a referral. You provide those services are able to be billed out, and you're able to help that patient as a CHW. Can the referral come after the services are provided? Yes. It just needs to be documented, okay, within your EHR. Again, as I said, it can be reimbursed through Medicaid, and it enhances care coordination. I just want to cover how we got here. CHWs is a long time coming, okay? I think I've been talking about CHWs since I was 23, and I'm not anymore. Okay, 2023, we had a House bill passed, 1028, okay? That told Medicaid they had to figure this out. I love Medicaid. They didn't want to do it on their own, though. Okay, so the House bill required them to do it, and it created a CHW task force. It was individuals assigned by the legislature that they had to all come together. figure out what the certification would look like, figure out what the continuing education would look like, and figure out what the billing would look like. The task force ended in the end of 2024. Lisa, I think, was their honorary member. We should probably get her a badge for that, because she was in every single meeting advocating for pharmacy every step of the way. But they came out with a scope of work, education, and training. They also talked about a CHW collaborative, right? We have a Pharmacy Tech Association, we have Pharmacists Association, we have Board of Pharmacy. They know that there needs to be a place for CHWs to come together to share resources, talk about challenges, talk about concerns. So in 2025, October 1, we launched the application. So CHW application is live. We're going to talk about what that looks like here in a second. Medicaid did file a state plan amendment, so we do have active reimbursement. And again, we're going to talk about that here in a second. And here is the code if you want to read the really fun administrative rules. Okay, it's so weird that on the screen it looks different than on mine. Okay, anyways, there are 3 different teams as of last week that exist to support CHWs at the state level. I will tell you the caveat here is the Rural Health Transformation Grant is going to change this a little bit, okay? Because there's been a request for an influx of money to support CHWs, which is great. It just means the work is going to shift a little bit. But for right now, you still get me. Certification. Again, we're going to dive into this pretty intensely here in just a second, but there are 4 pathways of certification: training and internship, CHR, so for our tribal communities, community health representative training through IHS, supervised work experience, it's my favorite, and reciprocity with another state. As I said, Medicaid is really owning that Medicaid coverage. They're going to monitor claims and reimbursement, and they are going to work on provider enrollment. And then me, currently, we're working on doing some supporting documentation, providing technical assistance, developing resources, and supporting that establishment of an association. So let's talk about what the different pathways are, because this is what everybody wants to know, is who qualifies. I will tell you, as my experience with pharmacy techs, working with the CAP Center, working with the Pharmacists Association, the vast majority of pharmacy technicians will meet the work experience qualification, okay? What that means, and because I'm going to jump down here, because this is where most folks are going to fall. The individual that's applying for certification has to have at least 1,000 hours over 3 years doing something that a CHW would do. You ever looked for a coupon for a medication? Helped work through a claim so a patient could get, their meds all aligned? Clearly, I'm not a pharmacist. I'm just totally honest. You just have to have an ish. If you feel comfortable that this person would be a great CHW, you don't have to show the documentation of a timesheet. I'm being serious. You, as a supervisor, just have to say, yes, this person has met 1,000 hours in the last 3 years, and I recommend them. The CAP Center has a template. Dr. Skoy has a template that I have quietly drafted that you would be able to use. Keep it simple. Okay, don't make this rocket science. They don't want your fluff. They just want to know that this person is qualified. Okay, seriously, I promise. Let's talk about the first one. So we are currently working with the in-state pharmacy tech program to add on in the future a CHW component to that. So someone could come out as a pharmacy tech with the education required to also be a CHW. Okay, so that's in the future. There are tons of CHW programs out there. My recommendation, this is just Tiffany speaking, if the person meets the supervised work experience, have them go through that pathway, and we would be happy to provide you a bunch of education if you feel like they're missing some things, okay? Don't have them spend $1,500 and 9 months of their time if you feel like they truly have a good grasp on the work, okay? Again, this training is through IHS, so if that applies to your program. And then reciprocity with another state. What that means is they have to be currently certified in another state like South Dakota, Minnesota. They could provide that certificate and show still that they meet the requirements of the core competencies. And those are on your handout. Okay, the core competencies are on your handout. But they are very generic and there are no definitions. State statute did not allow for definitions. Okay, let's talk about a billing example. CHW pharmacist identifies a patient. Pharmacist initiates referral. CHW delivers the service. Documentation supports the claim. It's really that easy. So CHWs is a time increment billed service. So you can bill in 30-minute increments up to 6 total hours of service before any additional documentation is needed, okay? So that additional documentation that kind of opens up the patient to more than the 6 hours is a care plan. Basically, how are you gonna get them off of CHW services? That's really all you have to document is what are you gonna do or what are you doing with your CHW and that patient to improve their outcomes? Yes.
Day, month, year.
There is no restriction within that. It's 6, they get 6 hours. I will tell you, I did highlight this. Hold on. Look, I have the really fun Medicaid rules right here in front of me. They're really exciting. A patient can get up to 52 hours a year in billed CHW services. So every 6 hours or 12 units, right? Because we're billed in 30-minute increments. So every 12 units or 6 hours, they have to have an updated care plan. Medicaid's definition of a care plan, a couple bullets, right? Like really simple. And so again, if the patient has a chronic disease and they're not taking their medication, what kind of care plan would we come up with, right? Helping patient coordinate transportation to get to the pharmacy or coordinate delivery, right? Helping them get to the food bank so that food isn't an issue and now they can pay for their medication, that kind of thing, okay? So Medicaid, again, reimbursement for a CPT code. You guys probably want to know what that is, right? I heard a yes. Okay, hold on. I got it written down. I'm just not following my notes because I'm just chatting. The code is 98960. Again, a 30-minute increment is $34.27. Okay. There are a couple other bill codes that can work for Medicaid patients if there are multiple patients you're helping at the same time, meaning a family. If you're helping a family unit, there are a couple other bill codes that can apply to those scenarios as well, but I'm just trying to keep it fairly simple here. So implementation considerations, again, I do not expect that you hire somebody. I want you to think about how you already within your workflow screen, refer, and follow up. Okay. How are you going to document? Training and continuing education, that is something that at the state level, we are absolutely happy to help with. I know the CAP Center is happy to help with. As you identify needs, make sure you let us know and really think about leveraging CHWs for those quality metrics. One project that I work on with the CAP Center is related to student rotations and using P4 students to help with chronic disease management. If you didn't pick up one of these books, make sure you do that outside. This is the blood pressure and diabetes kind of toolkit that we worked with the CAP Center to help develop. Honestly, this could be in every CHW's pocket, right? When we think about managing chronic disease. Case study, I think I have to have this on here. We've talked so much about it. It truly is something that I see CHW technical assistance as being one-on-one. You all reach out to me, let me know what questions you have. You reach out to Lisa, you reach out to Liz, you let them know what questions you have, and we will help walk you through it. The first step of this process is truly to just fill out the application. So on this handout, you'll see the link to be able to go to the CHW certification. So you first go through the statewide certification. There is a $30 or $35 fee. I don't remember what they landed on. One-time fee, and then every 2 years there's a renewal. Okay, 12 hours of CE over 2 years. That's it. And that'll be helped and supported by the state. Okay. Then after you get your CHW certification, you go through the Medicaid provider enrollment. So your CHW will be a provider within Medicaid's system. Okay. Then if you're going to be providing Medicaid expansion, they would need to go through that as well, but at least get through the Medicaid and then provide the service. Okay. Any questions? Yes. Nope. Nope. All your pharmacy techs could be CHWs. Absolutely. And there is no maximum or minimum to the amount of times they have to bill it, right? Because I know, obviously, based on Medicaid's presentation, there's a whole bunch of you that are Medicaid providers and are not billing a darn thing, which we need to have a conversation about. Big pet peeve of mine, sorry. But yes, I mean, they could bill 1 hour a month. They could bill 1 unit a month. They could end up being like their entire time, and one person becomes, if you're of a busy pharmacy, the vast majority of their position could be that, right? So there's a lot of opportunity there. Yeah. Does not have to be a technician. Nope. As long as they kind of do that work and you feel like they do that resource, that referral, that community connection piece, absolutely. My thought is just that a lot of times pharmacy technicians are doing a lot of that face-to-face work. And so how could we utilize them as well? And again, it could be everybody that's not a pharmacist in your office could qualify for a CHW, and all of them could go through that process. And then whoever happens to be helping that patient, they're the one who bill it out, right? There's no limit to that piece of it. And as we talked about, they could do the aging screening. They could do some of the other things that we've talked about today, because that is their role, right? Yep.
As skilled with
Mhm.
is there a hub of like, this is my zip code, these are some of the community support resources available? Fargo, First Aid, 211-988, you know.
Great question. Yes. So the question for those online was, how do we get people connected to the resources? The first thing I would direct you to is your local public health unit. Local public health units, while their resources may be outdated, they're at least better than maybe what we've got. If you have a student, we have had amazing Year 4, P4 students create resource guides for our rotation pharmacies. So charge them with that. We could give them some examples of what that looks like. Last but not least, the Rural Transformation Grant. I know this is a couple years down the line. The Rural Health Transformation Grant does have a lot of money built in for a statewide community information exchange, a CIE. So we can, if you decide that you want a CHW and you're going to put a person through the application process, reach out to kind of any of us, Dr. Skoy, Lisa, myself, right away, and we can help you get those resources ready for them. A lot of it is boots on the ground. But again, this is why a CHW is so beneficial, because they know about that one church that does the Wednesday dinners that nobody else knows about, right? They know about that one lady who does XYZ and can provide that support and service that maybe wouldn't be on a CIE. But kind of, yes, in a whole lot of different ways. But I'm happy to help with all of those things.
Decided foldable document with probably 200 resources.
Mhm. Yep.
Which I promote to our pharmacy students and different folks. So every community will need something like that.
Mhm.
Throw that out there. Resources.
Yeah, for those online, Dr. Strand just said that Fargo Cass has a really great resource. And yes, almost all the public health units pre-COVID were tasked with kind of creating these resource guides. Again, some of them are pretty outdated, but it would be a place to start. Yes. Yep. They may not have to because your CE, so the question was if you're a technician and you're a community health worker, do you have to do both pots of CE requirements? The answer is really no, because the CHW requirements could absolutely overlap with your technician requirements, as long as you're not talking about, I'm again not a pharmacist, how to inject an immunization clearly doesn't fall into the CHW realm. But if you're talking about legal and ethical responsibilities of working with community on private health information, that falls into both categories for me. So there is nothing to say this is a pharmacist CE and this is a pharmacy tech and this is a CHW. It's going to be a generic CE that you would just say falls into the category and could absolutely fall into both. And the goal of the pharmacy tech program at NDSCS is going to be not a standalone CHW and a standalone pharmacy tech. It's going to be how can we braid them together so somebody just comes out with both, but doesn't necessarily have to do more work. We just edit what's already happening. Everybody just wants to ask a question for the folks online, and we do have an online question also. Yes. Yes. Yep. Because it would fall underneath the CHW, and then it would fall underneath the pharmacist or the pharmacy that is doing that service. So I also want to address a question. I know it would fall more within health systems. Can an RN also be a CHW? And the answer is no. So if you are already a rendering provider within the Medicaid system, meaning the provider, the MD is the provider, but maybe the nurse is providing part of that service, that nurse is still listed. They cannot also be listed as a CHW, okay? But because a pharmacy tech is not listed within Medicaid as the rendering provider, they can also be a CHW within the Medicaid system. Yes.
You gave an example of like
Yeah.
as long as I see health promotion or seeking for health services such as other vaccines, then that could be tied to.
Absolutely. Absolutely. Yep. So if you take a look on my handout, so top right is the core competencies. If you take a look at those, you could find a whole lot that a pharmacy tech falls into within those. Now, I have not attended pharmacy technician CE, so I'm sure there are some that maybe don't fall within, but I will tell you that the certification arm at HHS does not want to micromanage this. Okay, there is 1 hour of legal and ethical CE that's required over 2 years. That is the only like sub definition or requirement. They just want it to fall within these very open-ended core competencies. Yes, Dr. Squay's question was, how do CE that would fall within pharmacy technicians like health promotion also fall within CHWs, and that you can double dip? And the answer is yes, you can double dip. Usually that's a no, right? Can't double dip. Online question. Just North Dakota patients. So it would be, so if somebody lived in North Dakota but was seeking services in Moorhead, for example, that CHW would need to be certified with the state of North Dakota. They could go through reciprocity if they're already a Minnesota CHW, and then they would have to register with North Dakota Medicaid. There is no, okay, so the question is about a state board. There is no state board that regulates. So that's why CHWs are a little different. They live in administrative code. So that means that we have a certification and licensing arm within DHHS that manages like EMS, for example. They're the ones who are managing CHWs. So there is not an outside board. It is currently state-led. Will that change eventually down the line? Possibly. But that is how it passed through the legislature, and that was what is required. So we just are rolling with it. Yeah. Yep.
So is that just a delivery of that is available?
It is not. So here's what I'll tell you. When you look at this really fun Medicaid document, it does not tell you what a CHW can do, but it tells you what a CHW can't, okay? Which I actually kind of like better, right? Because it allows us to be flexible within the needs of our community. So when I said you could go out to the home and do an aging check, for example, online question was, can you get reimbursement for delivering meds? The answer is generically no. Could that CHW, if they're going out to do a falls prevention check within the home, also just happen to bring the meds with them? Yes, they can, right? So you're not billing out for that service. You're billing out for doing the falls prevention check, but you're offering the convenience of bringing that med with them and probably doing other checks while you're there. So could you do, oh goodness, what's it called when you coordinate so all their meds come at the same time? Thank you. I've worked in this field way too long, but I did just get back from Disney. So want to talk Disney, I'll bring all the terms, but MedSync was not coming to me. So, could you help coordinate that in the pharmacy and then coordinate a check? And now that's 2 billable units, 1 on each side, right? You're coordinating services within the pharmacy, MedSync, maybe trying to get them a discount through GoodRx or whatever else. All of that's a billable service for your CHW. And then now you're going to do a falls prevention check in the home. It is. It all falls into that care coordination. Yes.
Now that this is all coming to fruition, that that there's going to be a lot of resources that are needed for pharmacy technicians and pharmacists, and that we're working with NAPT as well, trying to come up with what is needed, and it's a list of what they can bill for, or whatever that might be. So some of these resources are coming, but that also in the meantime, I think the biggest thing, like you said, is getting your certification. So going through that process and also the Medicaid process, so when all these additional resources are there, you're kind of ready to figure out whenever. Yeah.
So the question was when are the resources coming? When's all the additional support coming? I will tell you, because of Rural Health Transformation Grant, because we are getting additional dollars, it's kind of made things a little wishy-washy right now. So in the meantime, I'm your point of contact, so you can just email me any questions. I would be happy, like I said, if you want to reach out to Dr. Skoy or Lisa to get a hold of me and to schedule time. One-on-one technical assistance with you is absolutely something I'm happy to do. If you are applying to be a CHW or you have a staff person and you want to just physically get on a call with me, happy to do that. We will not be conducting roundtables. Sorry, y'all. We're kind of doing it right now. So one-on-one technical assistance is available, but yes, we hope to have a lot more come. What I will tell you, I will advocate for is not a list of what a CHW should be doing. Because the minute when we start saying what they should be doing is the minute we're also limiting what's going to be reimbursed, okay? What I would say, and I've worked very closely with Medicaid throughout this entire process, is bill it, bill it, bill it. Ask for forgiveness if it doesn't work, or ask questions why it doesn't work, and let us know about it. This is all new for them and all new for us. But I will tell you right now, as of last week before I went on vacation, we only had 10 CHW applications in. I almost cried because I've got a list of about 40 people that should have already applied. So get your applications in, start the process. As soon as you're approved as CHW, then you can start your Medicaid process, and then you'll be ready to go. And then we're there to provide support. Okay. Any other questions? Okay. I'm going to be sticking around, so if there are any other questions, otherwise, thank you.
This is a great day. I just thought the speakers were so good. So let's just take a moment to recognize Natasha Petrie, Lanika Rorick, Carly Smithers, Ryan McGrath, Jamie Stieg, and Tiffany Knauf for their presentations. And we're appreciative of the many participants who joined on Zoom, and we hope that your experience was very engaging and meaningful as we've tried to provide this in a hybrid format. And so excited to see such a good attendance, and we expect to be using the ballroom next year. So spread the word for next year's meeting. The CE slide should be